So that study was an interesting study. It was a study that was looking at an adaptive design for treatment. There was actually 3 studies that looked at this sort of strategy of, there's toxicity that's associated with nivo-ipi, from an immune-mediated adverse event standpoint. And there were 3 studies: Omnivore, Titan, which was a European study, and the HCRN trial, which looked at basically starting patients on a nivolumab backbone, and then based on whether they did or didn't have a response, layering in the ipilimumab to see if the ipilimumab was able to convert those non-responders into responders, or those patients that had progression. And I think when we look at that data in its totality, we actually, even though we're not kind of doing cross-trial comparisons to 214, but we just didn't see as high response rates with this strategy. The CR rates were lower. So I do think that as a field, doing dual, when you're going to use nivo-ipi, doing dual combination up front is the preferred strategy, as opposed to starting nivo and then layering in the ipi. But I think what we also observed is that there does appear to be a subset of patients, though it's small, but there does appear to be a subset of patients, and we even observed this on the Omnivore trial, that does seem to derive benefit from nivo alone. The problem is it's hard to know who these people are up front. And the Omnivore study was actually designed where if somebody had a CR or a PR within 4 to 6 months of starting nivolumab, they actually were allowed to stop all therapy and just be monitored. So this concept of treatment-free survival. And of those patients, roughly about half of them at the last data cut, when we presented the data, were still in a state of lack of progression without treatment. So I do think there's something to be said about this strategy. And we are even observing that in people who have favorable risk disease. I think that there's more that we need to understand about the biology and biomarkers that are going to help us determine, well, who are the people that could get away with that and who are the people that need more. For one, there's been extensive work looking at the transcriptomic signatures of these tumors, and work from Emotion 150 and Emotion 151, which were studies that looked at the combination of atezolizumab plus bevacizumab. And from those studies, we were able to discern that there are some tumors that have a more angiogenic signature, and they seem to respond more to VEGF-based therapies. And there are some tumors that have a T effector high, myeloid inflammation kind of low signature that seem to be primed to respond to IO therapy. And it's interesting when you overlay the IMDC risk factors on these signatures, there's a preponderance, there's an increased proportion of patients who have an angiogenic signature who have favorable risk disease. So I think this is why we're kind of seeing this, the data that we're seeing with regards to the favorable risk patients. Like, not to say do they derive benefit from IO? I do think that they do, but sort of they seem to really be responsive to VEGF. However, we're not really at the point right now of using these signatures to help with risk stratification in the context of trials or predicting. There isn't, they're not CLIA available signatures where I could just order it and get this test result back and tailor my therapy around that. We haven't gotten there yet. There are trials that are looking at doing that. Brian Rini is coordinating the OPTIC trial through Vanderbilt, which is using the transcriptomic signature to try to allocate patients to either nivo-ipi or nivo-cabo. But there's, I think to really do it right, you would have to take the biomarker negative patients and randomize them to the 2 options, and take the biomarker positive patients and randomize them to the 2 options. And a trial like that will ultimately change the field with regards to biomarker selection, but we're not there yet.